So part 3 of my final portfolio, professional practice, starting with ethics. So one important distinction I made at the start of each session was telling patients that I'm a 4th-year athletic therapy student versus athletic therapist, as I'm not an athletic therapist, and that would be a lie. Telling them I'm a student is transparent. They're understanding that I'm not a professional yet. I'm still learning, and by telling them I'm an athletic therapist, I can get in trouble potentially from the association. Furthermore, regarding ethics, I made sure to practice within my scope and knowing my limitations. With some patients, there were times where I had to make 2-part referrals, so things for things beyond my scope of practice. For example, I made a 2-part referral for a chiropractor where I thought a adjustment may have been indicated for a patient. I also requested imaging to understand the pathology that was occurring for one patient. There were neurological symptoms. There were neurological signs and symptoms indicating the patient had a disc herniation in the neck. As treating a disc herniation may have required surgery, and if that was the case, athletic therapy may have been minimal help for that patient, so I made sure to refer for things that were beyond my scope of practice. So in this case, the referral was necessary to rule out the need for surgery and also get a deeper understanding of the pathology at hand. So for communication, I frequently asked my patients if the exercises I were prescribing were engaging. So this was important for me. I asked so that I can get an understanding of how likely they were to complete them at home. And I think this is important to get their input because that helps build a relationship, letting them know that this is a 2-person relationship and that I'm also looking for their input within their rehab, and I want to get them involved. There were times when I was communicating with my patients where I would use the wrong words for my patients. So for example, I was explaining to a patient how to do a row, and I asked them to retract their scapula. This was an issue that was pointed out by my supervisor, as the patient may not, number one, the patient may not know what a scapula is, and number 2, they may not know what retract means. So this can be confusing. So I needed to remind myself about the language I use and adapt. So if someone knows anatomy, I can use more anatomical terms like scapula, retract, as that will help. But if they don't know, I need to remember to use lay terms. So things like the wing blades, I think they're called, shoulder blades, things like the shoulder blades, and pulling them backwards. As I stated in activity 2, I was having trouble completing charts on time. It was a combination of being unfamiliar with the charting system and not knowing what details to put into the charts. I remember roughly writing down an exercise, then going back to include details like patient position, cue, weight, after being told by supervisors that I needed more details. After getting more practice, I was able to become more proficient and more comfortable with it. So at first, I really needed the 10 minutes at the end of each session to get them complete. But as I got more proficient, I would always plan to leave an extra 10 minutes at the end of the session. But sometimes the session would cut into that 10 minutes. However, I was still able to complete my charts for the most part because I was becoming more proficient. Charts were completed on time for the most parts, unless I had to write a 2-part referral. I don't think I left enough time for that. The first time I had to write a 2-part referral, I had never done it before, and I made mistakes, and I had to consciously think and take my time to write down as much detail as possible and make sure all the pertinent information was on there. I remember when I wrote my first two-part referral, it was cutting into the next patient's time, the next session, but luckily they were late, so I was sort of let off the hook on that one instance. Despite this, this is definitely something I need to work on, so that number one, I'm not behind schedule in future practice, and two, I'm not cutting into the next patient's time. So not every patient is going to be late. I'm not going to luck out all the time. If need be, I'll be sure to leave more time at the end of each session if I do need to write a two-part referral. This may cut into the patient's treatment time, but the trade-off is that they're receiving better care by getting that referral for something that's beyond my scope. So when my patient canceled, one time my patient canceled and my activity was to teach the first year that was shadowing me certain anatomy lessons. After doing so, my supervisor told me that I was communicating the lessons, that the way I was communicating the lessons and the analogy that I was using were really good, and meaning that they were helpful in helping the first year understand what I was trying to teach him. And then I noticed that after the first year was quizzed from my supervisor based on what I tried to teach them, they got it all correct, which means my communication with them was good enough so that they can, one, understand, and two, pass a test pass some basic quiz questions. So when I assess my patients and I tell them my iOS, I like to pull out the anatomy model usually and explain the pathology so that they're more invested in the treatment and rehab. So if when I do that, if this communication is anything like when I teach the first year, that means it is reflected, or it is effective, regardless of how self-conscious I am about my communication, or regardless of how critical I am of my communication. I know that based off that experience that I had with the first year, I know it is effective, so I should stop being so hard on myself. And usually when I do communicate with my patients, I always make sure, when I do try to explain the injuries using the anatomy models, I always make sure to ask my patients if what I said made any sense. In the future, I'm going to continue to do this, pulling out the anatomy model and making sure they understand the injury. That way there's more buy-in from them. And then if an anatomy model is not available, I can always use a textbook, an anatomy textbook, or I can always use my phone. So as I stated in activity one of my goals was to develop better rapport with my patients. So with my patients who like to talk, I ask them things about their program. So one of my patients who really liked to talk was in athletic therapy. They were in their third year, and reflecting on my time in third year and the time of the year it was, I put myself in their shoes and I asked, what was I going through at that time? So I was able to have a conversation with my patients every week, asking them about how their time in the program is going. And I think this helped build our relationship. As I spoke about in activity 4, I had a patient ask about the origin of their injury since they were unsure. So it was important when they did ask, it was important for me to listen, acknowledge, and acknowledge what they were saying, address their concerns, and then inform them of what was happening. So communication for me is it's just as important for me to be able to explain to them as it is to understand and listen to them. I think it's important to address questions honestly with your patients regarding injury, as answers people can sense when you're lying or if you're unsure about things. So if I can answer a patient's question, they gain more confidence in me and my abilities. But if I can't, I tell them I don't know, because I don't know, and I'll get back to them, because lying is not going to help with my rapport, and saying you don't know but getting back to them is more important for rapport. It means that you don't understand, that's okay, but you're committed to learning and you will get back to them with the answer. Regarding collaboration, so when learning in class and assessing our classmates, there's always, and doing our mock assessments, there's always a mini debrief at the end of the session. And this is where I like to inform my partner what went well and what didn't go well with the assessment. And this allows us to reflect on our performance, but also be honest with ourselves about how we did. Working as a team in the clinic, I wasn't able to collaborate with another peer regarding a patient's care, but I did still work with them as a team, including doing things like managing who was using what plinth, the pillows, and also the modality cart. So the plinths had to be coordinated, as they're a limited amount, and there were always patients from overlap from the previous session. So we had basically two sets of patients, some of the overlap guys and then the current patients. So we always had to manage who is using what plinth. So I would ask classmates, hey, are you using this plinth? Is it okay if I use it? And then furthermore, pillows. There were just enough pillows in the clinic for 2 for each patient. Sometimes there were pillows lying around, but I wasn't sure about if my classmates were using them or not. So I would make sure to ask my classmate, hey, are you using this pillow? Would you mind if I take it before I take it? And then finally, the modality carts were limited, and ultrasound was only available on the carts. There was always a cart next to my plinth, and some classmates typically asked if it was available. Sometimes it was not, and I told them, hey, you got to find another plinth. But there was an instance where I had planned on using an electric modality initially, but at the time the patient was not in pain, so I was debating whether I should use it or just send them home. And then one of my classmates asked me if the cart was available, and at that moment I decided to change my mind. I knew applying the electrical modality was not going to be that beneficial for the patient anyways. So to benefit for both of us, it wasn't much of a sacrifice to go ahead and let my classmate take the modality cart. So regarding time management, there were times where I had to cut certain sessions short or take out less important bits or treatment techniques so that I was more efficient with the time, and so that I wasn't cutting into the next patient's time, because if I kept it the same, the treatment would be too long and it would start to cut into the next patient's time. Usually I cut things like exercises they could do at home that they already knew how to do, cutting out sets. So if it was 3 sets, cut down to 1, or treatment techniques that I was using to treat secondary complications. Generally, I like to keep my sessions 50% manual and 50% exercise. The way I keep this on track is frequently checking the time, so I know that by 30 minutes I need to cut down on the manual and start getting them to do exercises. But also I'm frequently checking the clock during my assessments, because I know that I can't spend too much time doing one manual technique, because then that would cut into time for other manual techniques. Some things that help manage my time with patient overlap was applying a heating modality with one patient while I escorted the other patient out. So usually I like to start my sessions by applying some sort of heat modality, then asking my history questions. But by doing this, I can escort my previous overlapped patient out while my initial patient, while my other patient is on a heating modality. So then they're not just sitting there doing nothing, they're having the heat applied. And then also this is useful because during my history, I can stop at any moment to go and escort my other patient out, and versus if I was to do something more involved like an ultrasound, that would be, I would have to pause it, and it would be sort of not, you don't want to pause an ultrasound, so it wouldn't be very effective to just pause the ultrasound, escort my patient out, then come back, continue the ultrasound. So that was one of the things I use for time management, the heat pack at the beginning of each session. At the end of each session, I needed time to chart because it's important for the profession. So as I stated in activity 4, at the end of the session, I apply the electrical modality and I verbally explain to the patient that, hey, I need time to chart. Give me a few minutes. I will answer any questions afterwards, after I'm done charting. Sometimes this worked. Other times patients like to ask questions anyways, while I already told them I need to chart. Usually I try to, when this happens, I try to give them a quick answer while I'm charting and then come back once I'm done, revisit the question once I'm done charting and provide them with more detail. So it's a, one of my first goals was to increase trust and satisfaction with my patients. I think both occurred, but with the trust was difficult to earn without satisfaction. I think I gained the satisfaction and then consequently the trust using objective outcome measures. With exercises, my supervisor helped me by asking, so to help increase patient satisfaction with the exercises, my supervisors helped me by asking me to remember their goals, the patient's goals, and try to reflect those goals through the exercises. So giving patients more specific exercises based on their goals was something that I think also helped gain the trust. Given the amount of time I had with patients, these goals were definitely realistic and easy to obtain over the semester, just because we had 10 sessions, an hour each. So it was fairly simple to gain their trust. I think I should have created a more challenging goal. I think this one was easy, but I think it was also only easy because of the help my supervisors gave me by constantly nudging me and reminding me to think about the patient's goals and meeting those goals to get that satisfaction and trust. My second goal was to become more familiar with conditions and pathologies. So throughout the ACP semester, I got to stick with 3 conditions through the semester. I got to learn specific techniques for each assessments and rehabs with the help of my supervisor. And I also got to learn how to progress with exercises from acute stages to later healing. My supervisors assisted me along the way by reminding me about the stage of healing for the patient and always reminding me to try to progress the patient's exercises. My final goal was to get better at finding the cause. At first, I did make some mistakes. So for example, as I stated in activity 1, I failed to get information on my partner who was a dancer. The type of dancer was going to be important in finding the cause, as some dances might involve more rotation, while other dances might involve more extension. For my patient through the semester, I was able to find the cause through a thorough history portion of the assessment, and my supervisors definitely assisted in this development by encouraging me to ask more questions about that one part of the history that is sounding concerning or it sounds like a key piece. So you guys pushed me to ask those further questions. I think I was able to develop through all learning outcomes this semester. So with professional development, I was able to look professional, start and end each session on time, and also finish charting. I think not only was I able to accomplish all these learning outcomes, but I was able to learn the importance of each professional outcome. For me, learning the why is more important, as I'm more likely to implement something when I know why it's important, rather than just following something because somebody told me to. In assessing, I was able to develop a repertoire of refined assessment tools. Narrowing down a special test I thought was most important for each condition that I felt comfortable with. I felt I made a lot of growth in my abilities to do PIVMs and interpretate information gained for rehab. In treating, I was able to critically consider exercises and manual techniques for what they are accomplishing and how to apply them to a particular patient with particular pathologies, which I thought was important. I got comfortable doing things like massage, and more importantly, I found a way that was comfortable. I found a way that works best for me as an individual. The time management skills was definitely something I was surprised about. Not something I expected to receive. Being able to rapidly but effectively go through a rehab program, not spending too much time on one thing, leaving time for exercise and leaving time to chart is something I started to be more proficient and aware of towards the end of the semester. It's also definitely something valuable I'll apply to my career going forwards. And this is definitely a thing I'm most proud of during my time to develop during my time in ACP is it's a skill I thought I had in other spaces, but not in the clinic. So being able to develop that time management in the clinic was important, and I'm proud of that. Seeing my supervisors, so seeing my supervisors use their hands, demonstrating an exercise or massage technique, was something that stood out for me. Their touch was never alarming. Their touch was always firm but confident. And this is something that has taken me some time to develop, and typically comes after building trust with the patient. So they're getting it the first try, and it takes me some time to develop that confident touch. To me, I think this is important because hands can communicate to the patient how confident you are. Also, seeing how frequently my supervisors wanted me to reassess my exercises made me reconsider the recipe of progressing after 2 to 3 sessions. I can always add more weight or change the lever of the exercise before changing the exercise completely to a more challenging pattern but same muscle group. So I'm definitely going to be keeping a lookout on whether or not my patient's struggling with their exercise, or if it looks like it's too easy, and progressing them week by week rather than a few weeks at a time. I think having the first year's shadow us was definitely helpful in my learning. Taking the initiative to explain to them what I was doing so that they were more involved helped me with my confidence in my treatment. While it helped me to hear as I explained to them, and I explained to them what I was trying to gain and why I was doing it, it reminded me that it gave me more confidence and reminded me, hey, I know what I'm doing and this is effective. And it also offered the first year a chance to be more involved and ask questions rather than stare aimlessly at the wall or a patient. I reflect when I was in first year, watching, and I was very bored. At the time, I was eager to learn, and that's why I was in school. So while I wasn't told explicitly I had to explain to the first years, this is something I took upon myself so that they can learn and try to be better future therapists, getting a head start in their learning and asking questions. I felt comfortable doing this because I remember being in the same position, wanting my fourth year to try to explain some things to me. When continuing to develop professionally, I want to try to make sure that I'm not implementing something new I learned into every treatment. So if I take a course, I don't want to introduce that new thing that I learned in the course into every single treatment. I know that's not effective. I think new things, new techniques that I learned, they should be weaned in first to try to see things if it's effective, and then based on the success I'm seeing with one patient, I may start to implement it with another patient. To continue learning, I planned on attending graduate school in rehabilitative science or a related field. I want to get more involved in research and learn how to be more critical about research. As a professional coming across new research in the field, I want to be able to better evaluate how effective this new research or intervention really is based on the research design. And only then, after critically assessing the intervention, then implementing it, and not with every patient again. Starting to wean it in. In the future, I think I would like to work in a clinical setting. With CEUs, I first want to try some courses that are common practice, like fascial work, for example. Since I commonly see this implemented, I would try to see if those techniques have any success in the clinical world before including those in each session. And then finally, I think I would like to explore more concussion rehab, since our knowledge in school for concussion rehab is sort of limited.